afternoon. I'd like to thank the organizers for having me here to speak about this. Like I stated, the first to see if we could make any, or draw any meaningful conclusions about growth hormone therapy and the safety of treatment in children with Costello syndrome. Just by way of explanation, I'm an assistant professor of pediatrics at Thomas Jefferson, but I work with Dr. Grip at AI DuPont. She's in the genetics division, I'm in the endocrine division. So just briefly, what I hope to do from the outset is to discuss the three syndromes that have been the focus here this morning, primarily Costello syndrome, but also to mention Noonan syndrome in the context of signaling of growth hormone, and as well as CFC, as you've heard. It's characterized by high birth weight, neonatal feeding problems, curly hair, coarse face, nasal papilloma, cardiomyopathy, and mental retardation. Just because there's so many varying levels of experience and background in the audience, I just want to go through some things on a very basic level. I realize that for some people in a few minutes I might sound like I'm flying at 30,000 feet, but I want to go over some of the basics first. Growth hormone is a decapeptide. It's not a steroid hormone. It's produced in the pituitary gland, which 80% of the pituitary gland is devoted through somatotropes to the production of growth hormone. It has mitogenic properties, and it works through the JAK-STAT system. Growth hormone receptor is a dimerization of growth hormone that works through the JAK-STAT system, which may have important implications in a subpopulation of patients with Noonan syndrome. It also works through the IGF-1 system. IGF-1 stands for insulin-like growth factor 1, also called somatomedin C. Growth hormone goes to effector cells, which then produce IGF-1, which signals through its receptor. And this signaling through homologous IGF and EGF and insulin receptors results in activation of SHP2 pathways. The IGF-1 receptor is very similar to the insulin receptor. It's a heterotetramer with a tyrosine kinase properties. So recently defined etiology in many of the cases, invading germline mutation in HRAS proto-oncogene. HRAS, in my preparation for the talk, I learned was the Harvey-Red sarcoma viral oncogene homolog located on chromosome 11, short arm 15.5. HRAS mutations were detected in 12 of 13 individuals with Costello syndrome that were tested by Dr. Aoki, who I was pleased to see here this morning, and 33 of 40 tested by Dr. Grip, and that's the area that I'm going to focus on, are the 33 patients in Dr. Grip's study. So the pathway you've all seen over and over again. The reason I wanted to put it up again is to talk specifically about Noonan syndrome as being slightly different in terms of growth hormone signaling compared to the other two syndromes. And I hope to elucidate this as I go further in, because this system is modulated by the JAK-STAT system. And I've been treating probably on the order of 10 to 15 patients with Noonan syndrome, many with growth hormone over the last 13 years. And reviewing the literature and looking at our own patient population, there were two very distinct populations. There were patients that responded to growth hormone with an accelerated growth velocity soon after initiation of treatment, and those who just were non-responders. And recently, some of this may have come to light by Dr. Binder, which I'll mention further into the lecture, as to why there are some patients with growth hormone resistance in the Noonan syndrome population. Noonan syndrome is autosomal dominant, have a Turner-like face, short stature, webbing of the neck, also called pterygium, cardiac anomalies, deafness in many, motor delay, and clotting disorders. If you can think back to the diagram I just showed you, after a growth factor binds to GRB2, or growth factor receptor bound protein, located on the gene for which is located on chromosome 17q23, a cytosolic adapter protein with SH2 and SH3 domain complexes with PTPN11, or protein tyrosine phosphatase non-receptor type 11, also known as SHP2. This has been found in roughly 45% of patients with Noonan syndrome, and these mutations may confer growth hormone resistance, which has generated a trial of recombinant IGF-1 in these patients. IGF-1 has recently come to market as a recombinant therapy for patients that are non-responders to growth hormone. And in the Noonan syndrome study, what they've done is give growth hormone as a trial to most of the patients to see if they can generate IGF-1. It's an IGF-1 generation test. If they're growth hormone resistant, or if their mutation is known that they probably are going to be resistant, then recombinant IGF-1 can be given. Recombinant IGF-1 comes with its own special problems. First of all, instead of a once daily subcutaneous injection like growth hormone, it's twice a day. And it can induce hypoglycemia in some patients, so it's very important that they eat when they get their IGF-1. It has a lot of crosstalk with the insulin receptor. CFC, congenital heart disease including pulmonic stenosis, ASD, hypertrophic cardiomyopathy, high forehead bitemporal narrowing, hypoplastic supraorbital ridge, depressed nasal bridge, angulated ears, sparse hair, thickened skin, developmental delay. And I do have a CFC patient in my population. Thanks again to Dr. Grip. The etiology is KRAS, which is the rat sarcoma 2 viral oncogene homolog located on chromosome 12. Also BRAF in the majority of patients, which is a murine sarcoma viral oncogene. Schubert et al. And Nihori et al. In Nature Genetics demonstrated the KRAS heterozygous mutations in 1 of 12 and 3 of 43 CF patients respectively, and BRAF heterozygous mutations in a much larger population of 16 of 40 patients. Rodriguez-Vinca et al. In Science showed a heterozygous mutation in BRAF in 18 of 23 CFC and activating mutations in MAP kinase 1, MAP kinase 2, and in 3 of 5. So, from our study, what can we say? Costello syndrome and growth hormone deficiency. Data from Dr. Grip's study, plus 2 patients added since the time of publication. 16 of 35 Costello patients had documented growth hormone deficiency. That's 46% at the time we published. And I can tell you that after interviewing many families yesterday, I think it's probably a much higher percentage than that. A lot of them just haven't been tested. 13 of these 16 received growth hormone at some point, which is 37% of the entire group. Costello syndrome, cardiomyopathy, and growth hormone treatment. 14 of 35 Costello patients had some form of cardiomyopathy, but only 6 of these 14 received growth hormone treatment. I'm sorry if this data is slightly different than what Dr. Lin just presented, but it's close and based primarily on the same population of patients. She has a slightly expanded population. She went into it in much more detail previously, but down the bottom there, I just want to say that 8 of 14 of the patients in this study of Costello syndrome cardiomyopathy cases were naive to growth hormone treatment. Costello syndrome tumors and growth hormone treatment. 7 of 35 Costello patients had tumors, including 4 rhabdomyosarcomas, 1 pituitary adenoma, 1 benign bladder tumor, and 1 bladder carcinoma. Of the 4 rhabdomyosarcoma patients, 2 never received growth hormone. 1 received growth hormone 5 years after tumor diagnosis, and 1 received growth hormone prior to tumor diagnosis. The benign bladder tumor received growth hormone after tumor diagnosis. The pituitary adenoma and bladder carcinoma both received growth hormone prior to tumor diagnosis. Of the 7 Costello patients with tumors, 4 or 57% were naive to growth hormone prior to tumor diagnosis, and 3 or 43% had received growth hormone prior to tumor diagnosis. 2 of the 3, or 29% of the total, were malignant. Again, I apologize that the N is so small, but this is a rare disease, and unfortunately, the N is small. Costello syndrome, growth hormone treatment, and growth velocity. The data on growth velocity revealed an increased growth velocity in the 5 Costello patients who had received growth hormone treatment and had documented growth data available with several growth points obtained over time. What I've learned as I've come to these symposiums every 2 years is that I have to change my way of thinking. When I first came, I only wanted to rely on my own measurements because in my practice, when I rely on outside doctors' measurements, they're notoriously inaccurate, many times using the metal piece on the back of the scale and sitting it on the child's head while they're moving around. So I thought if I collected my own points, I could get more accurate data. The problem is the paucity of data. So even though I had those two separate symposiums, I didn't have a lot of data, but the data that I had is convincing that growth hormone definitely will increase growth velocity in these patients. So Costello syndrome growth hormone treatment, arguments in favor. Well, documented growth hormone deficiency in 46% of our cohort, which, as I said previously, I think is probably much higher if they would all get tested. Hypoglycemia with syncope or seizures, there have been several case reports. Growth hormone is one of the 4 counter-regulatory hormones for insulin. It helps you to maintain your blood sugar, and if you're fluoridly deficient, you can drop your blood sugar and have a hypoglycemic seizure. So even if your endpoint is not that you want to improve someone's final height, to keep them metabolically stable if they're fluoridly deficient, this is a good idea. Severe short stature. These patients are very short. I've measured a lot of them for the 3rd time yesterday. The vast majority of them have a height standard deviation that's -5 standard deviations below the mean. All are less than -2 standard deviations below the mean, except for 2 children that I saw yesterday. And that qualifies you for an evaluation for short stature and growth hormone deficiency. Arguments against. The arguments against have become weaker in my mind as I've sat through all the lectures at this symposium. Tumors, HRAS is a known proto-oncogene, but if you look hard at the data that I just present, the number of patients that had malignancies that were naive to growth hormone were just as large as the number of patients who had malignancies after exposure to growth hormone. Hypertrophic cardiomyopathy. The reason I mention it here, just to augment what Dr. Lin said, is in patients with growth hormone excess or acromegaly, adults, hypertrophic cardiomyopathy is a known complication. So this is a reasonable thought when a pediatric endocrinologist is faced with a child that they've had on growth hormone, who's had worsening hypertrophic cardiomyopathy while on treatment, especially at a young age, as to whether or not to stop the drug. And then finally, obstructive sleep apnea. I found this reference before I came to the meeting, Delamarca et al. From the American Journal of Medical Genetics. 7 of 10 patients with Costello had obstructive sleep events, and 100% had narrowing of the upper airway. I'd like to mention it in the context, not as a direct comparison, but as an analogy to Prader-Willi syndrome. Prader-Willi syndrome patients, it's an automatic indication for growth hormone, but in the last 2 years, the Lawson Wilkins Pediatric Endocrine Society has come out with a position statement that was generated because there were 7 deaths of Prader-Willi syndrome patients within 6 months of starting growth hormone. When you look closely at that data, those patients were probably at more risk because of how heavy they were and the amount of pressure on their neck, as well as adenotonsillar hypertrophy. But in patients with Costello syndrome, I think this is a consideration when starting growth hormone. If they've had documented sleep apnea and have very large tonsils, I think it should probably be addressed prior to growth hormone treatment and definitely be discussed with the family. So Costello syndrome and IGF-1 treatment, Barreca et al. In the Journal of Endocrinological Investigation showed an increased IGF-1 clearance due to the reduced presence of acid labile subunit. Acid labile subunit is crucial for IGF-1 to work to augment growth. If you have rapid clearance of these factors, it may explain part of the etiology of poor growth in these patients. This is purely hypothetical, and since IGF-1 has just come to market, I doubt that we'd be able to do it anytime soon, but it may be a thought in the future that if you have a growth hormone non-responder, a child that's gone through the algorithm for testing for growth hormone deficiency, been put on drug, and has not had a significant acceleration in their growth velocity, and you can't show that IGF-1 pre-treatment has changed much post-treatment, then it may be a thought that IGF-1 could help those patients. There's an ongoing trial on Noonan syndrome, as I said, to circumvent the growth hormone resistance that's conferred by PTPN11 mutations. And then finally, what I wanted to say is purely hypothetical. Costello syndrome and growth hormone deficiency, why does this happen? As soon as the reports of the mutation came out, I thought about this as much as I possibly could, and I went and read a lot about it, and I talked to all the experts in the field, and really nobody had an explanation. One of the best explanations that I came across is that there could possibly be, due to the fact that this is an activating mutation, increased somatostatin tone. Somatostatin is a hormone that works to downregulate growth hormone secretion. Growth hormone releasing hormone comes from the hypothalamus, causes growth hormone release from the pituitary, and if there's increased somatostatin tone, you can shut down the peaks of growth hormone. You need a pulsatile, you need growth hormone to be secreted in a pulsatile fashion for it to work. And then finally, I just mentioned Chiari-1 malformations because there's a known association of growth hormone deficiency in non-Costello patients. So it makes perfect sense to me that there are patients with Costello syndrome and Chiari malformations that we need to probably look more closely at the pituitary and make sure that they don't have small pituitaries or ectopic posterior pituitaries, which are both known to cause growth hormone deficiency. The bulk of the pituitary is crucial in terms of cell mass for the normal production of growth hormone. And I'd like to thank you for your attention.